For those of you who have been following the series that we did on addiction, if you remember, we gave you some statistics about the epidemic of drug abuse in the United States. We said 1 out of every 4 families has someone with drug abuse problem. We also said that 80% of those who are incarcerated in the United States, in all the prisons in the United States, are there for drug-related problems. Those are alarming statistics. 1 out of every 4 families has someone with drug-related problems or drug abuse problems. And 80% of those who are incarcerated in the United States are there for drug-related problems. Now, some of them are there for very minor drug offenses like marijuana abuse, smoking weed, but some are there for very, very serious drug-related problems like selling sex for drugs or drug trafficking or killing people for drugs. But we decided to go to the prison system in Maryland and speak to the medical director of the prison system in Maryland, and just to find out about the kind of care they give to prisoners in Maryland prisons. And we went to talk to the medical director, Dr. Baucom. Thank you, Dr. Baucom, for joining us and for taking time off your busy schedule to speak to us today. Dr. Baucom, can you take us through the healthcare system in the prison? Can you take us through what really happens to a prisoner from the time they come through the door to the time they see a healthcare provider like a doctor or a physician assistant?
Absolutely. Dr. Ayeni, Maryland has a distinct honor of being certified by the National Commission of Correctional Health Care, even though the Baltimore City Jail is one of the largest jail systems in the country, at least in the top 10. From the beginning of entry into central booking, they are greeted by a registered nurse-level practitioner who conducts what we call a preliminary intake receiving questionnaire. That questionnaire is completed after the booking process to alert us to chronic diseases, acute medical problems, both mental health, substance abuse, and a litany of communicable diseases that are most commonly seen in a socioeconomic class of poverty from which a number of these inmates come. So we're very proud of the fact that upon entry, the opportunity to help greet that inmate with clinicians who have a dedication to this kind of public health service is there in the jail.
Good, good. How about those who have been using IV drugs and have contracted HIV illness or hepatitis? Is there a provision for their health? Do you take care of their health too in the prison system?
Absolutely. It's interesting that some inmates and detainees, arrestees coming into the correctional system are hesitant to confess any kind of communicable disease, HIV, hepatitis. However, once they understand that they are not going to get out on bail, that they're going to be housed with us for a while, they begin to volunteer to the practitioners that they do need help with these conditions. So in partnership with Johns Hopkins, the Institute of Human Virology for the University of Maryland, we have developed an excellent HIV infectious disease program. The practitioners have direct access to specialists in infection control and HIV. So along with video conferencing, telemedical, chronic disease clinics, their access to the state-of-the-art medications that are used for these conditions is readily available. When we look at the opportunities for barriers to treatment, we certainly understand that correctional environments make it a little bit more difficult for people to feel comfortable in admitting that they have these conditions. Again, whether it's the nurse, a social worker, the chaplain, or their case manager, the opportunities to understand how to access the medical system in corrections is there.
Good, good. Johns Hopkins. I believe Johns Hopkins has been rated the best hospital in the world in the last 5 years. If you are sending these inmates to get health care there, I believe they're getting one of the best health care in the world.
We don't even have to transport that inmate into the institutional bowels of Hopkins to receive that expertise. We have scheduled 3 days a week the opportunity for that inmate to sit in front of a camera with their clinician by their side and directly ask a Johns Hopkins specialist in HIV questions about their medications, their complications, and their disease. I'm privileged to have the opportunity to have the data that states that Maryland has a 64% viral suppression of the known cases of HIV inmates in our system. I say known because we do know that we don't have mandatory testing upon entry. So for those inmates who do allow us the opportunity to help them treat this disease behind bars, we have an ability, documentation-wise, to say we have a tremendous success in helping them suppress their viral loads, even in corrections.
Fantastic. Amazing. Now, those who come in who are withdrawing from, say, alcohol or heroin or methadone, how do they get treated?
In 2005, because of the department's commitment to facilitating treatment of substance abuse, we have an excellent program with drug and alcohol and substance abuse that is highlighted by the addition of 2 addiction specialists and nursing staff and medical physicians who support them, who have also had training in substance abuse and alcohol-related problems. As part of the entry questionnaire, the questions related to, have you ever had problems with alcohol or drugs? And if they answer yes to that, we do what other community organizations do. We conduct a specialized questionnaire that gives us some opportunities to rate the level of alcohol-related problems through a test called a CEWA. And along with opiate addiction, there is an additional questionnaire called a COW that you can fill in the initials, but the whole thing is geared toward making us aware of the severity of the impact of that disease on the inmate. We rapidly identify who they are, and if they have an existing spot in a community detox program and need to have their methadone continued behind bars, we substantiate that, start them on their methadone, and continue it throughout that incarcerated stay with us. We noted that our data showed a number of inmates coming into the Baltimore City Jail had withdrawal symptoms directly related to alcohol, and subsequently were sent off site to local emergency rooms for treatment related to seizures. That let us know that we weren't being proactive enough in identifying those patients and treating them with more than just an opportunity to have antacids and something to give them so they don't vomit, but nothing that actually prevented them from withdrawal. We've corrected that And in fact, the culture of the opportunity to humanely approach an individual who has this chronic disease of alcoholism, I think has been so successful that other inmates who come into the system now understand that if they identify themselves as having problems with alcohol, we conduct that survey. We place them on a newly formed, in the last, 3 years, an alcohol detox unit specifically geared to support them through the worst and the acute severity of this problem in a humane fashion, and again in partnership with our addiction consultants and the nurses and the custodial support, because without custody education with respect to the agitation that could create violence from people going through withdrawal, without custody making sure that they have access when they themselves spot inmates who maybe have not volunteered that they have withdrawal symptoms, because the education from the addiction specialists and the nursing team have alerted custody to those symptoms, they are at the forefront in assisting us in also identifying those inmates and making sure that they're placed on that unit.
Good. Incredible. Have you noticed reduction in the number of patients that are being sent to the hospital for alcoholic withdrawal or alcoholic seizures since you initiated your detox unit?
Absolutely, and we have the data to support that. We are very happy to report to the Governor's Committee and to the Secretary that we can quantify and qualify through quality assurance audits that we have significantly reduced the number of off-site community ER trips directly related to alcohol and drug withdrawal, such that we're not only protecting the inmate, but we're protecting the public from the opportunity for public safety issues surrounding escape or problems with inmates who have some violent tendencies upon entry into community institutions. By not having to have them go off-site, we've protected both of those populations, the public and the inmate.
Yes, the issue of methadone, I'd like you to elaborate more on that. In the past, we were told there was not much cooperation or collaboration with community opioid treatment program. But here things have changed now since you initiated the methadone interim program in-house. There's now more collaboration and cooperation with community providers, and patients that were on methadone on the outside, when they come into the prison setting, you're able to find out how much methadone they're using, and you've been maintaining them on methadone. Is that a correct representation?
That's absolutely true, in the sense that community organizations who do support citizens who become inmates through activities directly related in terms of their drug habit, whether it's burglaries or armed robberies, they want to humanely approach the management of those kinds of cases and reduce recidivism in terms of people getting out without treatment, coming into the community without treatment, and creating and committing crimes to support a habit. So once we have this partnership of advocacy, both in the community and in corrections, we recognize that even COMAR legislatively advises that we have an obligation to support and continue people who have successfully entered into treatment programs in the community. So in 2005, in recognizing that obligation and opportunity, we wrote into our existing medical contract the methadone maintenance and detox obligation of the contractor to help us support the community continuity of that treatment.